But the ones that are symptomatic, there's about 80, for every 100,000 people, there's about 80 patients who end up seeing a medical professional for their DVTs. About 50% DVT patients end up getting some sort of PE. Now that sounds like a lot. It's because a lot of those are actually silent PEs. These are patients who, just get some tertiary, secondary branch, subsegmental PEs. They don't have any decrease in their oxygenation. They're on room air. They're fine, but they did get a PE. They just are showing it. That's why a lot of times when you notice that the patient gets a DVT, they get a PE protocol CT, even if they're not showing symptoms, because they are looking for those PEs. And that does change the management a little bit. Most patients get 3 months of anticoagulation for their isolated DVTs. If you have a DVT component, PE component to it, generally we'll make that to 6 months. Complications from DVTs. Now this is kind of where we get involved. Early complications are obviously PE and phlegmasia, limb threatening, which I'll go over phlegmasia, what it means, what the signs are, what the pictures are under assessment. And then late is post-thrombotic syndrome. This is why we actually treat any of these patients, because post-thrombotic syndrome is real. It can be very painful, very debilitating for these patients. It's not life-threatening, but it can really cause issues for them. Unfortunately, their veins, so these patients, there's not much you can do once they get post-thrombotic syndrome. There are bypass procedures and things, but there's nothing really that works. That is shown to work long-term. Any bypass you do to venous system is bound to go down. It's a low-flow system. Sometimes you even put in fistulas to keep the flow higher. But even those eventually go down. So it's a tough situation for these patients once they get post-thrombotic syndrome. I'll go over a little bit about what that is. It's just basic anatomy of what we're dealing with. You have the tibial veins, you get the popliteal vein, it goes up to the deep femoral vein. Now, just nomenclature-wise, this is something that was recently changed, and a lot of hospitalists and ER docs still don't really call it this. And this is really the reason I put this on here. It's not a superficial femoral vein DVT, because that is confusing, right? That implies that it's in the superficial system. If it's in the SFA equivalent of the femoral vein, it's just called a femoral vein DVT. If it's in the common femoral vein, you say common femoral vein DVT. That's just for you guys to know when you're talking about this, because this nomenclature was changed fairly recently, maybe about 10 years ago. Because before it used to be called superficial femoral vein DVT, femoral vein DVT. Well, you can imagine that superficial femoral vein DVT makes people think this is superficial, not a big deal, don't treat, and it can lead to problems. So, that's why we call it that. Then, you have the external iliac vein, the common iliac vein, and these usually what will happen is if you have a complete thrombosis of a femoral vein, or the common femoral vein, you almost always have some DVT up in the external iliac. The reason for that is the clot's it's not like arterial stenosis where it's just going to be focal, right? If it's a DVT, it's going to travel up. It's going to go to the next branch point generally, which means usually the confluence of common iliac vein right here. So if you have, and I'll go over the ultrasound in a little bit more detail in subsequent slides, but if you get a DVT that says complete thrombosis on the study, it says complete thrombosis of the common femoral vein, assume that DVT extended to the iliac vein, because there's no way that it just stopped there if it's completely thrombosed, because the blood is not moving, it's going to thrombose, and it's going to thrombose further up. So just one thing to know. A lot of times they won't say on these ultrasound reports, there is an external iliac vein. You have to kind of tease that out based on what they're saying about the common femoral vein. All right. So one of those words on there, phlegmasia. There's two kinds of phlegmasia. There's phlegmasia alba-dolens, and then there's phlegmasia ceruleolens. Alba means white, cerulean means blue in Latin. Alba is, you see this picture here. It just looks like a wicked swollen leg. It's painful white edema, common in pregnant and postpartum women more so than the regular population. This is a total iliofemoral occlusion of the venous system. And it's, however, there's no, usually the reason this hasn't turned into ceruleia or worse or venous gangrene is because the superficial venous system is still open. Now, the patient has had if the patients had GSV ablations, vein ablations and stuff, they're probably never going to get this. They're going to go right to the other one that I'm going to show you next. But this is something that, basically these patients have wound threatening, but they're not so bad that they're going to lose their leg that night. They need something done. Most of the time you see something like this and the patient's in a lot of pain, we end up treating this and you'll end up sending it over to Hartford anyways. Or we'll do it over there if it's during the day at Bacchus. But this is somewhat of an emergency, and it's something to be concerned about. And you have the edema, pain, blanching without cyanosis. Now, the interesting thing that some of these studies have shown is that 40% of these patients that have a DVT this bad will have some sort of malignancy. So if they have an completely unprovoked DVT, be concerned that there may be a malignancy involved. And that's something that needs to be worked out. Usually, that's why we get, we almost always admit these patients to medicine at Hartford, at least, because if they're unprovoked, completely unprovoked, we want to know why that's happening to them, and it's not just a fluke. So, that's something we want to do. Now, these can evolve into what's called cerulean dolens. I'll show you that next. That's obviously on the second part of the paradigm here. This looks pretty bad, as you can tell. Anyone would look at this and say this person probably needs something done. Occlusion of both deep and superficial. This can lead to what's called venous gangrene. Venous gangrene really sucks. And that basically means, it's not an arterial thing where you can just go in and thrombectomize it, and then the patient will be good to go. Venous gangrene, they're going to lose that leg. So this is very important. Now, both these patients require compression immediately. They require anticoagulation immediately. But these patients require treatment. Both of them do, but these especially emergently require treatment. Signs and symptoms: fluid sequestration, significant edema, pain, and sometimes they'll have bullae as well, and then cyanosis. Compartment syndrome and acute ischemia later on can result. Now, this is very interesting. You look at cyanosis, you look at bullae. What else do you guys think that you might confuse this for if this patient came into your ER?
Compartment syndrome, right?
Sure. Yeah, no, that can certainly, it'll be nice and tight, and they won't be able to feel their first web space. Anything else you commonly see in general surgery consults? Soft tissue.
So neck fash.
Neck fash, exactly. So neck fash actually a lot of times this looks like neck fash. The reason I'm bringing this up specifically is because I remember when I was a chief resident, the ER had a patient like this come in, thought it was neck fash, sent it, called general surgery. General surgery went and did a fasciotomy without really, I guess it was the resin value or whatever they're doing. They went, took him immediately, did the neck, the fascia was totally fine. And then 3 days later, they called vascular. Turned out the patient had a complete iliofemoral DVT, and this was cerulean dolens. We had to go in, because they had already done the fasciotomy, we couldn't do lysis. We had to do an open venous thrombectomy. It was actually the only open venous thrombectomy I've ever done, where you literally cut down to the femoral vein, and then you milk out the clot from their leg as you're just squeezing on it to get it all out. And it's a bloody affair, it's a pain in the ass. But it's just important to know neck fash versus this. And the reason is you can call 2 different services for that. If we can help it, we'd rather just do this in a lytic fashion and not do the, because once you open up the fascia, you're not going to do any lysis. The patient's going to bleed a whole lot. So it's important to know that. You're going to see bullae, you're going to see cyanosis, you're going to think this is neck fash, but make sure you get a DVT study too. Ensure that this isn't, phlegmasia and not neck fash. All right, post-thrombotic syndrome. This is the late stuff, not something that you really will see immediately in the ER. You might see patients come in with sort of complications of post-thrombotic syndrome acutely. It's a late complication, leg swelling, leg pain, skin discoloration. So, we talk about the venous stasis hardening, and so the woody-looking skin you can see on here on the right, and varicosity sometimes can occur, and venous ulcerations, weepy wounds, etc. Now, these are basically these patients will come in. They have, sometimes they basically have this very chronically swollen leg. They're miserable. They're young, and they don't know what to do. They wrap their legs. It doesn't really help. They're very frustrated, and then they'll get a wound that's not healing. They'll come to the ER. The ER is actually going to call you and say, this patient has limb ischemia or some sort of chronic limb issue. You're going to feel their pulses are palpable, but they have all these wounds. And quite frankly, this is really hard to treat. you have to do venous reconstruction, which, like I said, doesn't really work. There have been some patients where we've opened up their iliofemoral system with different mechanical devices, but even those, they don't stay open for a good while. The biggest indicator of post-thrombotic syndrome is if you have iliofemoral DVTs, and that's why we'll go over the protocol in a second, and that's why that's so important. If you have iliofemoral DVT and you don't treat it, you're going to get post-thrombotic syndrome, almost guaranteed. The best way to minimize post-thrombotic syndrome is early heparinization, early anticoagulation, and compression. That will help. If it's quite a bit of clot burden, then we can go in and do some interventions of the lytic therapy as well as the mechanical thrombectomy with the Inari. But this is with the patients that we see quite often in my clinic. Why I started this whole protocol was because these patients will come in. They'll have cable thrombosis. They'll have iliofemoral DVT, that May Turner, what have you, and they'll go home on Eliquis from the ER. We'll never hear about them. They'll come to see me like 6 months later. Well, there's nothing really I can do about that at that point. Their clots completely hardened. They made some collaterals, obviously not enough. Now the only thing we can really do is continue compression and anticoagulation for the rest of their life. Or if we want, we do a big whack and do a cable reconstruction or a palm-up procedure, which is basically taking a GSV, reconnecting it from one side to the other on your iliac veins and creating a conduit, which usually goes down within a couple of months to a year because the patency is not that great. So kind of limited options for these guys. And these are the patients you will most commonly, or we at least in vascular surgery most commonly see, who've had these DVTs and haven't gotten them treated. Now, ultrasound-wise. Now you'll see the report. Obviously, you'll see thrombus. I'm sure most of you know if it's non-compressible vein, there's acute DVT. If it's non-compressible and echogenetic, if it's nice and bright, it's chronic. Now, if it's acute, it's very unlikely it's going to be bright. So that's something you see. Sometimes it's subacute, so you'll see a little bit of both, and that's why you'll see that on the report. Now, one thing on the report, which may or may not be mentioned, but you can always pull up SECTRA and look at it yourself, on PACS rather, is the respiratory variation on ultrasound. This is actually my biggest reason to go ahead and treat these patients. So like I said, if you have complete femoral vein DVT or femoral vein thrombosis, you'll have extension into the external iliac vein to be assumed. However, this is another sign. If you have occlusion of the external iliac vein, what you'll see is in the common femoral vein, for instance, on the right side in the control, if it's normal, you'll see what's called respiratory variation. As a patient breathes, you can see this patient's just breathing probably, normal respiratory rate, and you can see that, you see this. On the left side, this patient has a DVT extending into their iliac vein, probably external iliac thrombosed completely. You barely see any respiratory variation. It's essentially flat. When you see a flat line like that, on Doppler, on the ultrasound, you know that this thing is an iliofemoral DVT, and this is a concern. Now, sometimes these texts won't mention that in their note or in their report, but now that you guys know what this looks like, you can easily assess that and say, okay, well, this looks like something that needs to be, discussed with vascular surgery about actual treatment. Because this patient, I guarantee you, will come back with PTS because they're not going to clear this up. All right. You guys have any questions about this?
No.
Treatment option, all patients, every single patient that comes in with DVT, compression, anticoagulation. Okay, the compression's very important. Now, the reason I harp on that is because the chest guidelines say everyone with a DVT should get compression almost immediately. Now, for whatever reason, in nursing guidelines, there is some. I'm not really sure where it comes from. It's not really some sort of obvious data, but they are taught that if a patient has a fresh DVT, do not put compression on their legs because their worry is that you're going to dislodge something and cause a PE. That's absolutely false. And it's because of that a lot of patients that come in with a DVT won't have compression on their legs. And you'll see nurses being hesitant on putting compression on their legs. I dealt with this all the time when I was in training, but you just have to make sure they have it. I'd say immediately from toe up. whether it's with an ACE wrap or TED hose, whatever you have. Compress them, the earlier the better. Even if they're going to get the severe stuff, you could potentially prevent that by just having early compression and anticoagulation. So you bolus the patient, bolus the heparin, and you start one systemic heparin. Severe cases, we do systemic lysis, catheter-directed lysis. This is basically just what's called ecos, where we place the catheter right in their iliac veins or into their common femoral veins and just grip lytic therapy overnight. For these, we usually have the patient come into Hartford because they have to have ICU stay because there's a risk of brain bleed with these patients. And then mechanical thrombectomy. This is a device that I've sort of brought to the healthcare system. It's called Inari. I can actually quickly just go online and just show you what it looks like. I didn't put a presentation in. It's kind of out of the scope here what we're talking about. Look at this. This is what it looks like. I'll just show you this. This is what I generally use for a lot of our patients, and they tend to go home within 23 hours. This isn't required at any thrombolytic
The
agent.
Inari clot retriever system is an important new treatment option for venous thromboembolism, enabling the extraction of large clots from big vessels without the need for thrombolytic drugs.
I'll just mute this. So you hear all that. But basically the way it works is you have this basket, you put this through the popliteal vein generally, and then you collect, this big sheet goes into the popliteal vein, that basket comes out, and you basically squeegee out. See here, you just squeegee out all that clot. Pull it out, and the way it works, you don't need any lytics, you just need a stiff wire, and we're able to get all, you guys can see right there. We usually like do 4 or 5 passes and most of it comes out. Now, as they're doing manipulating, you can't really get a PE because it's protecting the basket. It's a pretty sweet device. These patients go home, within the same day, within 23 hours usually, when we do them in Hartford. I'll probably start doing these at Bacchus too at some point. We just haven't had the inventory. It's, they've been having issues with that. All right. So that's that. And then open venous thrombectomy, you'll never see this. This is sort of medieval stuff you only do when someone's already had open surgery. It was before the mechanical device that was. Now, this is the meat of it, the DVT protocol. So now that you guys know about all those things, DVT. Patient comes into the ER, DVT. Can they get anticoagulated? If yes, if they can't get anticoagulated, if yes, call vascular surgery consultation. Now, most of these patients, if they have this is just to simplify. I had this whole thing about calf DVTs and what to do, this and that, but honestly, they're going to call us anyways. So it's easier if they can't get anticoagulated, they call us. Whether they need a filter, we'll do that, or you have discussion, have questions about anticoagulation, we can take care of that. If no, is an iliofemoral DVT on duplex, based on what we talked about. I didn't go into the respiratory variation or any of that stuff with them. This is for the ER because I don't know if they're actually looking at these PAC systems and stuff. But this is something you guys can easily do. If it's yes, put the patient on heparin and then call us. If no, does the patient have phlegmia? Very unlikely. This is really put into cap for everyone, but unlikely they're going to have iliofemoral DVT and still be phlegmatic. All right. Now, for whatever reason, if the report doesn't say it and they have what we showed you, then you know that that the patient probably does have, the report doesn't say it, but then corroborate, but then they do have phlegmasia. It's probably the report's wrong. So if they don't have that, 3 months of anticoagulation per whatever choice the ED wants, re-imaging for chest guidelines. The reason I wrote that and not put exact things is because the chest guideline changes almost every year. Most of the re-imaging is within 2 weeks, and then they usually do it every 3 months. But the important part is follow with PCP, not with us. So if they don't have an iliofemoral DVT, they're not getting any surgical intervention from us, and they're not severely threatened or severely symptomatic, they don't need vascular surgery consult. So every popliteal vein DVT, every tibial vein DVT, you should not be called. If you do, you just point into this box. Now, considerations, this is some extra stuff they need to consider. Limb elevation compression immediately. for patients. So they need to they need to leave the ER with this. If they're going to be in this box right here, they need to leave the ER with those things. You can't just say go home and buy some compression at some point. They need to get them right away because that thing can propagate into an iliofemoral DVT if they're not careful. And then for all unprovoked DVTs, we recommend a hem-onc consultation. Now, that's sort of the reason we recommend. We don't require it because that's kind of up to the ER and the hem-onc department. It depends on the hospital. This is going system-wide. Not every hospital is not every hem-onc and every hospital is going to want. I would recommend consultation for every unprovoked DVT. So that's kind of up to them. They can fight those battles, but that's not really for you to do. Just for you to know that that's what we're recommending for them. And all patients with new DVTs, every single one, whether it's iliofemoral, isolated pop, tibial, whatever, they need to follow up with their PCP. Because long term, we don't really need to see these patients. Even if I do the thrombectomy, the inartic thrombectomy, or the lytic procedure, I don't really need to see these patients again. I will see them post-op 1 month, but overall, to look at their post-traumatic syndrome and things like that, it really should be the primary care physician, and that person can kind of consult vascular, do the imaging, etc. This really keeps them out of our unnecessarily out of our office as well, because we end up seeing a lot of these patients who have no intervention. They just have swelling that's chronic, and what they need is through compression, and the PCP can certainly order those. So that's just more of an education thing, a systems thing for efficiency purposes. Okay, anyone have any questions?
Yes. Where does an IVC filter fit in your algorithm for patients that can get anticoagulated? Like a patient that has...
Any questions, guys?
Oh, wait. Can you hear us?
Sorry, it was on mute. Did you say something?
Yes. Can you hear me?
I can hear you now.
Okay. Where does an IVC filter fit in the algorithm for patients that can't get anticoagulated? Such as like a patient that has, a intracranial bleed, been in bed for, a couple days, intubated, and now has a DVT because of leg swelling. You can't anticoagulate these patients.
Yeah, so if the patient, if they have a head bleed or anything like that, that's where that comes in. So contraindication to anticoagulation, that's where that protocol in this protocol right here, if they have any sort of contraindication, you just call us, and that's when we decide. You're absolutely right. In that patient, that would be an IVC filter. I really didn't put that in the algorithm though, when to put an IVC filter, because I don't want the ER deciding that for us.
Got it.
You know what I mean? Because I never want you to get a phone call from the ER attending or PA or whatever saying, hey, we need you to put in a filter in this patient. Because that's not their decision. And you shouldn't be in that position to be like, oh, that's on us and we decide, and whether, if they're going to call us, then we decide, and, we can kind of figure that out. And you're absolutely right, although that's purposely why I left that out, because I don't want them making those surgical decisions.
Got it.
Question for you on the beginning part of your protocol.
Mm-hmm.
What, if the ER calls us, what is the proper imaging that they should get that will then follow with this decision tree?
Ultrasound. Now, they can get, and in my previous protocol, I had indicated that they can get a CTV, but quite frankly, what I would recommend is an ultrasound. Now, if at Bacchus they can't get the ultrasound in the middle of the night or something like that, then the CT venous phase is what they should do. But it really should be the duplex. That's the first and foremost thing we should get. Because really, you don't need the CT even to diagnose the iliofemoral DVT. Because like I told you, you can find all that out from just the ultrasound with respiratory variation and complete thrombosis. But I would say the CTA is only necessary if they don't have the ability to get the ultrasound.
All right, so if the ER calls and says, I got a guy, leg pain, swelling, I got the ultrasound, it's showing a DVT. Our next question to them should be, is it iliofemoral?
Yes.
And then following the pathway.
Absolutely.
All right.
And I mean, they should have this path. I've already talked to him. Is it Kyle?
Yeah.
I've spoken to him. I've gone over this protocol with him as well, and he's going to I think he'll talk to his colleagues. So they shouldn't call you unless it is iliofemoral. But if they do, you should just refer back to this, and you can still ask them that. But they really shouldn't even call you before they shouldn't call you unless there's ultrasound already cooking. There's no point in calling because you're still going to get that. And that's something I've discussed with them is that, what we find very irritating is when they say, oh, we have a suspected DVT patient. They call you, you go down there, the patient is not elevated, does not have compression on, has not gotten an ultrasound. And it's like, well, we need all those things anyways. So why, you don't need vascular surgery to do that, And I think that's something that we kind of made clear to them that they need to do some of the work before we show up.
So what's the idea behind the compression? Is that to increase venous pressure so you get blood flow and delivery of like thrombin and all that stuff?
Yeah, it's 20 to 30 millimeters of mercury. As you can see, limb elevation compression, knee high, 20 to 30 millimeters of mercury for all patients. Now, when you're doing ACE wrap, just wrap it tight. Obviously you're not going to be able to gauge how tight it is, the pressure you're putting the ACE wrap on, but just wrap it as, tight without being uncomfortable. Now, if the patient has palpable pulses, you don't have anything to worry about because, they're not compromised from a peripheral arterial standpoint. So the concern is, and this is something the gestalt is that if you have bad PAD, the arterial system, you have, ABIs are less than 0.5, etc. That's sort of severe to moderate range. And a patient has venous insufficiency, superficial venous insufficiency, we recommend no compression for those patients. That's in general, that's not for DVT. If you have a DVT, you gotta take care of this. So everyone gets compression. So, that I wouldn't worry about.
And you're saying there's no risk of making that clot move if
No.
you compress?
No, there's no. So they've actually done studies on this because there was a discrepancy between the nursing guidelines and the chest guidelines. And it's all equivocal data. There's no risk of compression causing DVT. That's it's one of those sort of old school teaching without evidence type things that have gone by the wayside since they've actually done, studies on this.
Okay.
So what's the physiology behind doing the compression?
So the physiology behind the compression is twofold. One is you're going to prevent post-thrombotic syndrome and endophlegmasia by keeping the superficial system open. If you're compressing the superficial system, you're forcing blood into the deep system, right, through the superficial system with the compression. And you're also forcing the body, the deep system, to create channels through the clot. So as it's becoming chronic, you're basically forcing it to create those channels. It's not going to dislodge and cause a massive PE, but it is going to force it to cause channels. Now, you gotta remember, acute DVT, the idea is that it goes from, day 0 to day 14 is an acute DVT. After day 14 is considered a chronic DVT. Well, it's not like on, 12 midnight on the 13th day, it just suddenly becomes acute, chronic. It's a continuum. Studies have actually shown that within 48 hours of a DVT, patients already have significant collagen deposition within the vein. So it's already on its way to become chronic by the time that you're seeing the patient in the ER. And if you start with the compression, you're going to create those channels so that chronic DVT doesn't become completely occlusive, and you have channels and recanalization channels through the clot. And that's what you see. A lot of these patients who are, religious with their compression and they get no surgical intervention, they just get anticoagulation. You see them in the clinic and you get a DVT study, and what it'll show is that they have the chronic DVT, but it's not completely occlusive. And you see actually in color Doppler, you will see the channels within the clot that the body's essentially created due to the increased pressure from below.
There's no activity restriction whatsoever, right?
No.
Obviously, you don't insulate and all that. Okay.
No, I mean, activity restriction as far as, in terms of patients on anticoagulation, shouldn't be doing certain activities, but contact sports, things like that. But that's not for the DVT, that's for the anticoagulation purpose.
Yeah. And also, like, I've heard it, it's always been passed down. Heparin doesn't do anything to break up the clot, it just prevents the clot from expanding, correct?
I'm sorry, say that again?
Is that, we've always been taught that heparin does nothing to break up the clot, it just prevents the clot from expanding or becoming larger.
Absolutely. The only thing that actually breaks up the clot is TPA. Now, it's endogenous TPA, the one that your body makes itself, or is the TPA that we add to the mix. Heparin only prevents propagation of DVTs. So that's why it's very important these patients who are iliofemoral DVTs to prevent a PE, because the studies have shown that a PE is more likely with an iliofemoral DVT than with a popliteal isolated DVT. It's imperative that these patients get anticoagulated.
How long do you apply compression?
So for these patients, depends on what kind of DVT it is. If it's iliofemoral DVT, I actually recommend lifetime compression. Obviously not religiously, but lifetime compression for these patients because their valves are never going to come back. But in terms of just treatment, what we say is, compression during the time that they're getting their anticoagulation. So 3 months, 6 months, depending on how bad it is. But most of these patients that I see in clinic, I tell them, wear compression whenever you're out, whenever you can. Because everyone will have some level of post-thrombotic syndrome. It won't be to an extreme, but there's very rare cases where the patient gets a DVT and they won't have any after. No compression, no swelling whatsoever after. That leg will always be a little different than the other leg, and they'll notice, after long high walks or drives, they'll notice that leg swells up just a little bit more than the other one. The biggest risk of getting a DVT is a previous DVT. So compression actually prevents subsequent DVTs. Because they're going to have some chronic stuff in there. They're going to have some issues with venous flow, and the likelihood of getting another DVT is higher than the general population. So compression stockings are, for that reason, indicated. Now, these patients after anticoagulation stop are back basically, while they're anticoagulated, they're actually protected, right? But after 3 to 6 months after they stop taking the anticoagulation, now they are more likely to get DVTs than the general population, and they're not anticoagulated. So the least you can do is recommend compression.
Where's the best place or the quickest place to look up the anticoagulation guidelines for chest? Because I already see the ER going, well, I'm busy, I don't have time to look it up. What should I send this patient out on?
But it says per ED.
I know, but they're gonna, even if we had an answer for them to say, look, www.this, look it up.
Right. So if you just Google test guidelines, they come from the American College. It's a consortium from the cardiology group and the pulmonology group. It's the chest guidelines. It's there. Unfortunately, it's a 70-page paper, but it does have all the algorithms. It has everything. They come out, they renew them every couple of years.
Okay.
So we kind of have to stay on top of it. But usually critical care docs, to them, that's just, they know that stuff. But it's important. Chest guidelines, they go over DVT, they go over PE, vent settings, PE treatment, etc. They also have a whole section just on DVT. If you go on, you can just go on and search for it and see it. If they ask you, if they for whatever reason don't want to treat their own patients, Eliquis or Xarelto are the way to go if they can afford it. Here, chest.net. Click on that, and then you will see the full text. It comes out every couple of years. I don't know if this is the newest one. But yeah, chest guidelines expert panel, and they have these every year. And then it just kind of go. It's long, right? But then there's a summary of recommendations on what you should do. It tells you exactly what you can do.
Perfect.
See that right?
All right. Any other questions? All right, thank you very much, appreciate it.
No problem, take care, guys.
All right,
Thank
good
you.
day.